Hi, hello everyone. Today we will discuss the liver function tests and viral hepatitis serology panel in this video. Liver function tests are performed to confirm a clinical suspicion of potential liver injury or disease, and it is also useful to distinguish between the hepatocellular injury and the cholestasis. The tests that are included under the liver function tests are bilirubin, aspartate transaminase, alanine transaminase, gamma glutamyl transpeptidase, alkaline phosphatase, lactase dehydrogenase, prothrombin time. Normal reference ranges of these parameters are bilirubin up to 1 milligram, alkaline phosphatase 25 to 112 international units per liter, aspartate transaminase 5 to 31 international units per liter, alanine transaminase 5 to 35 international units per liter, albumin 3.5 to 5 grams per deciliter, prothrombin time 12 to 16 seconds. Liver function test. Aspartate aminotransferase is non-specific. It is present in liver, heart, smooth muscle, kidney and brain, and it also varies with alcohol consumption, acetoaminophen NSAIDs AC inhibitors intake. Alanine aminotransferase is more specific to the liver when compared to aspartate aminotransferase. AST to ALT ratio, if it is more than 2, it is associated with alcohol hepatitis. AST to ALT is less than 1, then it is associated with hepatocellular necrosis. Alkaline phosphatase is elevated in hepatocellular and cholestatic disease. There will be significant elevation in the alkaline phosphatase levels, which will indicate the cholestatic disease, and it may be elevated in healthy children and pregnant women. Gamma glutamyl transpeptidase GGT, there will be concurrent elevations of this GGT with alkaline phosphatase indicative of cholestasis, and it is also elevated with alcohol, phenobarbital and warfarin intake. Bilirubin is a breakdown product of heme containing proteins hemoglobin and myoglobin, and the circulating unconjugated bilirubin is transformed by liver to the conjugated bilirubin by the process of conjugation. Unconjugated or indirect bilirubin accumulates with increased production or hemolysis and accumulates with decreased conjugation in Gilbert syndrome. Conjugated or direct bilirubin accumulates in disease that slow secretion of the bilirubin into the bile or the bile into the intestine. Prothrombin time. Hepatocellular disease with decreased protein synthesis of factors 2, 7, 9 and 10 will cause the variation in prothrombin time. Clinical implication of these abnormalities. Liver chemistry tests. ALT and AST will tell hepatocellular damage. Prothrombin time and albumin will help in knowing the synthetic function, and bilirubin and ALP, GGT, bile acids, 5-nucleotidase all will guide us in cholestasis or biliary obstruction. LDH helps in hepatocellular damage, but it is non-specific. Viral hepatitis serology. Viral hepatitis is most often causing hepatocellular pattern of injury, and in this AST and ALT elevations will be predominating. Patients who have no symptoms and in whom aminotransferase levels are normal may still be infected. Hepatitis A virus infection is a acute self-limited disease and rarely fatal. Diagnosis is made using antibody tests, anti-HIV. Positive anti-HIV IgM antibody is diagnostic of acute hepatitis A infection. IgM antibodies are usually positive at the time of the onset of the symptoms and will remain positive for 3 to 6 months after that. And in few cases, it will be up to 1 year. Anti-HIV immunoglobulins IgG develop later than IgM, but they persist for many years and offer the immunity. Anti-HIV IgG antibodies are also seen following the vaccination. If anti-HIV IgM and anti-HIV IgM and IgG total are positive, then it is diagnosed as acute hepatitis A. The presence of anti-HIV IgM irrespective of the presence of anti-HIV IgG will suggest acute infection, and the presence of anti-HIV IgG in the absence of IgM suggests the previous infection or post-vaccination antibody. Hepatitis B in adults produces hepatocellular enzyme elevations like that in hepatitis A. In adults who acquire hepatitis B, the infection almost always clears, but the antibodies persist. In a few, the disease does not resolve and becomes chronic. These patients retain the serum markers of viral infection. How to interpret whether a person is hepatitis B positive or not? If HBsAg, anti-HBc, anti-HBs are negative, then it indicates susceptible. HBsAg negative, anti-HBc negative, anti-HBs positive, then it interprets as immune due to hepatitis B vaccination. HBsAg positive, anti-HBc positive, and if IgM anti-HBc is also positive, then it is interpreted as acutely infected. If HBsAg is positive, anti-HBc is positive, but IgM anti-HBc is negative, then it is considered as chronically infected case. HBsAg negative, anti-HBc positive, and anti-HBs negative, then the possibilities of interpretation is unclear, and there are 4 chances. The most common one is it may be resolved infection, or it may be false positive, or low level chronic infection, or a resolving acute infection. Chronic hepatitis B is characterized by persistence of hepatitis HBsAg for a period more than 6 months with positive anti-HBc IgG and negative anti-HBs. An additional antigen antibody system plays a role in patients with chronic hepatitis B and requires hepatitis BE antigen and its antibody anti-HBe. HBeAg positivity in chronic hepatitis B usually indicates acute viral replication and there is a significant liver injury. In time, HBeAg may be lost, but it is replaced by its antibody anti-HBe. Hepatitis C infection usually produces no symptoms or it may be mild, non-specific flu-like symptoms. It is infrequently diagnosed in the acute phase. The virus clears spontaneously in 15% of the infected patients. Although generally helpful for the diagnosis of chronic infection, antibody tests are often not useful for the diagnosis of acute HCV infection because the emergence of the antibody is delayed for several months after the infection. To test for possible acute HCV infection, HCV RNA should be performed. When HCV is suspected, anti-HCV EIA is advised. To confirm the current infection, if anti-HCV is positive or if acute HCV suspected or in immunocompromised HCV suspects, HCV RNA PCR can also be advised. If HCV RNA positive and treatment contemplated, then HCV genotype test is to be done. If genotype 1 HCV and treatment is contemplated, then IL-28B from patient's DNA is advised.